वक्रतुंड महाकाय प्रभ निर्विघ्नं कुरु मे वक्रतुंड महाकाय
वाओ, देखा आपने गणेश जी के हाथ में IMS का लोगो नाच रहा था।
Thank you, Paresh. And with that, let me open today evening's webinar for everyone. Welcome to all, and my respects to the past presidents of IMS who are present here, Dr. Ambuja Chornoor, and I can see, and the present president, Dr. Anita Shah, and Dr. Ragini, and Dr. Bipasha, the past secretary. I'm really delighted that all of us are together here, because today happens to be the end of the present season for prescription workshop. And today's topic is very relevant because it is hormone therapy for cancer survivors, whether it is feasible, and also about in general about acknowledging the fact that as menopause care providers, we also need to care for cancer survivors in every way, not just MHT, but yes, we must provide MHT as and when possible. With that, since it is the last of the series, I just want to begin with expressing my heartfelt gratitude, and I acknowledge that I was given encouragement by Dr. Anita Shah, very, very magnanimous president of this year, and wonderfully supported by the enterprising Dr. Ragini Agrawal, and I'm very, very grateful for that. And it was a very good time I had with all the coordinators, with Lakshmi, Padmaja, and Anjana, and Reena, of course, very dear friend, and Jyoti Bhaskar. And of course, my senior, Dr. Revati, has always supported me for this. So thank you, everyone. And with that, I shall invite the chairpersons. No, I will invite the president, Dr. Anita Shah, to say a few words, and then Dr. Ragini, and then we'll invite the chairpersons. Over to you, Dr. Anita, please. Unmute कर लीजिए.
Yeah. Very good evening to all of you. Respected Ambuja Madam, dear Ragini, dear Bipasha, Shobha, Padmaja, Lakshmi is not there, Revati Madam, and all my dear friends. I'm sure that many of you must have enjoyed the prescription writing webinars. Actually, throughout the year and since years together, we are discussing a lot about menopause. And but we were feeling that though everyone as a healthcare provider knows each and everything regarding menopausal issues and their solutions, but we were very much hesitant to prescribe when it comes in our routine practice. And that's why we thought that let us plan out this prescription writing webinar. And with the help of dear Ragini and Shobha and all the coordinators, Padmaja, Lakshmi, Reena, Revati Madam, and Anjana, we planned these. And so happy that it all went very successfully. And today is our last webinar for the prescription writing. I'm sure you will take a lot of carry-home messages from that also. And so lucky that our beloved Madam, Dr. Ambuja Madam, is one of the speaker for today's webinar. So, Madam, heartiest welcome to you and our all other speakers, Dr. Seema and Dr. Ragini and Dr. Shobha. So I'm not wasting much time. Heartfelt thanks to all of you, and just let us carry on for today's webinar. Thank you, Shobha.
Thank you, Anita. Over to Ragini for her message for today.
Thank you, Shobha. Very good evening to one and all. Respected Ambuja Madam, President Madam Dr. Anita Shah.
Ragini, आवाज बढ़ाओ.
हैं, आवाज बढ़ाओ.
हाँ, वॉइस का स्लो आता है. हाँ.
देखती हूँ फिर मैं. अभी आया?
अभी आया.
अच्छा. बीना जी, डॉक्टर दीपा, डॉक्टर ममता, विपाशा जी, रीना जी, डॉक्टर रेवती मैडम, and our dear coordinators, Dr. Padmaja and Jyotika ji also there. We are really, as you said, Dr. Shobha, that every good thing comes to end. And today is the last webinar. And if any person, 1% you are be sure to write about MST, this whole prescription writing workshop is, we think it is successful. The message is gone across, and we have many learned speaker out of our IMS also. The only thing is that yesterday also in the webinar, my talk is on the early menopause in the cancer survivor also. So I just want to say one thing. If we see this slide, most of the cancer does not require to stop the MST. And we should be very sure these cancer survivors are very young. And if you are not writing and not giving them MST in time, we are really doing negligence towards their health. And it is necessary for these younger survivors to provide with the hormones, which is a really, really need of the hour. And I hope that today's webinar with our esteemed speakers, we are going to get benefited at all. And thank you, Shobha, for doing all the work. Just we started with this, and then you have done a wonderful work the whole tenure. Thank you so much. And over to you to take forward.
Ragini,
Thank
sorry,
you.
just I forgot one thing to say. We are trying to make a prescription writing book from all these webinars which we had conducted. And so happy to say that Ambuja Madam has peer reviewed all the modules which till today we have made. And today's will be also with the help of
Included.
Ambuja be able to
Yes.
complete. And I'm sure that we will make the prescription writing book. Thank you.
Yes.
Thank you,
We're very
Anita.
lucky to have Ambuja Madam as our, really, she's a godmother for us.
Oh,
Yes.
Yes, yes.
Undoubtedly.
Madam is ready
Undoubtedly.
at each and every webinar, nahi, Ragini? Even on the wellness weekend, early in the morning on Sunday also, Madam is there.
Thank you.
yes, see, that's the effort so much our people are doing. See, we have to encourage the people, no? Otherwise, if nobody turns out, what is the fun in that one? See, you're all hardworking, you are doing nothing, at least just presence. That makes you everybody happy. And that's one way that we all will meet and feel happy.
Correct, madam.
Yes, Madam.
Togetherness
Very
has a
right.
lot of value, especially on IMS forum. Togetherness is everything in fact, because
Yeah.
this is such a complex area of practice that we constantly need to get encouraged from and share experiences, so that we help each other to become better in this subject. Thank you very much, madam, for being here. Thank you, Ragini and Anita. I shall now bring in the chairpersons for today. Can I have the CV of Revati, madam, please? Dr. Revati Janki Ram is the past president of Vice of Madurai Manipur Society, and also she has been the vice president for Foxy. CV है क्या परेश? कि Okay. Madam has been a very senior teacher, and she has been the guiding light for many students. And I think showing a CV is a little bit redundant, but because she is so well known in the South and elsewhere also. As I said, for Madurai OBG Society also, she has been a very prominent figure, and Madurai chapter of Tapisar. She has won her own set of awards, the Lifetime Achievement and the Durusha Community Service, and she has been a master trainer for PPI UCD program, very, very close to my heart, this program. And she has authored several chapters also. So welcome, madam, and I hope that your presence will really bring out the best from the speakers. Next, I go to a very dear friend and long-time associate, our own very own Dr. Jyotika Desai, one of the gems from Bangalore Society. Can you please show me her Society of OBG? And she is a very, very ardent teacher, I must say. Many postgraduates look up to her teaching, and she really does a wonderful job in the postgraduate forum that we have at BSOG. CV hai, madam ka to de dijiye, please, Paresh. or I must say that she has made significant contribution to IMS also over the past few years. I think it is not a new news that what I am saying. We together conducted the IMS Con in the year 2020, and I can tell you, Anita, how we missed the pandemic by a hair's breadth. We were able to conduct, and then pandemic struck. So it was like God had destined that Bangalore should conduct IMS, and that was wonderfully done by Jyoti as the organizing chairperson, and I was fortunate to be the organizing secretary along with her. So, Jyotika, welcome to the forum, and please, both of you, please take this forward. I welcome the chairpersons to conduct, and please share the CV of the first speaker, Pareshji, Dr. Seema
Yeah.
Singhal. Thank you.
Thank you. Thank you, Shobha, for your kind words. And can I have the CV of Dr. Abuja? Really, I appreciate Dr. Shobha because this prescription writing webinar itself is unique. And this is a novel idea brought by Shobha under the guidance of Dr. Anita. And I doesn't know, 1 year has gone with a lot of webinars on this topic, which is very, very useful.
Thank you, madam.
So
Thank you.
first is, thank you. So the first speaker is Dr. Seema Singhal. She is a professor of OG department, AIMS, New Delhi, and she has been awarded UACC fellowship, traveling grant from Agoy, and Dr. Radhakrishnan National Teachers Award, and she treasurer in AOGI and joint secretary of Agoy, coordinator for drafting Foxy GCPR treatment of. She has done a lot of work on cancer cervix, and really it's going to be a wonderful feast for us. And I welcome you, Dr. Seema, to deliver your lecture.
Good evening, ma'am, and thank you so much for your kind words. And really, it's a wonderful opportunity for me to be there in front of all eminent senior faculties here today. And so I'll try to highlight some important points that we consider while we prescribe, when we deal with the postmenopausal symptoms of our cancer survivors. So I'll be discussing that in front of frequently asked questions and frequently faced troubles that we encounter in our clinical practice. I'll not go much into details of the drugs and all because that you are already, well acquainted much more than me, I guess. My slides are visible.
Yes.
Yes. You can just make it full screen.
Yes.
Yes.
So is it fine? Yeah. So let's begin with that. Yes, we have these gynecological cancer survivors who commonly experience treatment-related menopause, often after bilateral salpingophorectomy. They take chemotherapy and suffer from ovarian failure after radiotherapy, chemotherapy, and usually they are characterized by more frequent, severe, and persistent symptoms, much more than a normal population. And the natural menopause is not that much symptomatic as a surgical or the radiation or chemotherapy induced menopause is. And so they suffer silently most of the times. And as we know that cancer treatment therapies and everything is improving, the survivals are improving, and there's so much of pressure now, so much of concentration, so much of consideration of the quality of life of these patients. So here comes the role of menopausal hormonal therapy, which is so much important to relieve these symptoms for these patients. But yes, it remains a complex decision-making process because we need to understand that there is the evidence to support the safety of this therapy in all the gynecological cancer is limited. So we need to understand individually the sites and how safe which medicines are. So first, let's take one patient who's 35 years old who underwent chemoradiation for stage 2B squamous cell carcinoma cervix. So now this patient, what are her health risks? Most commonly, that is the question that is asked in the clinic. So this woman has sleep disturbances, she'll have vasomotor disturbances, mood changes, depression, migraine, genitourinary symptoms, bone loss, cardiovascular health, cognitive function, and osteoarthritis. So all these problems are going to be there for her. So what are the various treatment options? If we go, we all know there are two types of agents, non-hormonal and hormonal replacement therapy. So less effective are the non-hormonal agents, but definitely they are more effective than placebo. And here comes the role of gabapentin, SSRIs, and SERMs. But hormonal replacement therapy can also be initiated after individual assessment of benefits and risks. So options, the way we start for them is first, is foremost always is lifestyle modifications, which involves the healthy diet, physical activity, maintaining weight, and cessation of smoking, because it remains as a high risk factor for them. There are certain complementary or alternative medicines available like phytoestrogens, calcium, vitamin D, and cognitive behavioral therapies. There's a lot of work ongoing on cognitive behavioral therapies, but yes, we're not sure if this works or not. But then yoga is really working well for our patients if we advise them. Now, for survivor of cervical cancers, if we see there are few concerns. Yes, squamous cell carcinoma versus adenocarcinoma. Shall we give for adenocarcinoma also? Because it has been found to be associated with increased risk of estrogens. So, and then ovarian involvement, whether we can, work on their ovarian involvement, especially while we are managing them surgeries. So it has been found that in cervical cancer cases, the patients who were given HRT versus the one where MHT was not given, the survival outcomes were comparable. The cancer recurrence risks were comparable. So we have to remember. So we can give them MHT with full confidence as we decide. However, we have to remember when we are giving them the hormonal therapy, when we give them radiation therapy, the ovaries gets knocked off very easily, but the uterine lining, it remains. So whenever we are giving them, we need to give them estrogen plus progesterone therapy as per protocol. So that's one important point for them. Now, there are few important investigations that we should do for them before we advise them the therapy. These are the very routine investigations, specifically including PAP test or HPV test or a colposcopy, if indicated. And then mammography should be done for them every 2 years. And endometrial sampling is not routinely required in an asymptomatic patient. So that's one thing. And so when should we start the therapy? Yes, of course, it is individualized, taking into account the benefits and risks. And usually it is best when we start them before within 10 years of menopausal onset. So earlier the better. Symptomatic postmenopausal survivors, like, the ones who have genitourinary syndromes or prevention of bone loss or vasomotor symptoms, even the younger patients with iatrogenic abrupt menopause, like the way our patients are having the radiation. So how long? No consensus on optimum duration. Long-term exposure is avoided due to risk of metachronous breast cancers. But yes, it should be given ideally for the shortest possible duration, tapered gradually, and vaginal estrogens and other non-estrogen therapies may also be continued. Other modalities like non-hormonal therapies, SSRIs, these are also very good, effective for these patients, and other alternative therapies, as I already said. Now, can we preserve ovaries for cervical cancer patients? Yes, we can, for both squamous as well as adenocarcinomas, because the risk of ovarian metastasis for squamous cell cancers is really low, 0.2% to 2%. It is a little bit higher for adenocarcinomas, like 4%. So if you're operating a younger patient below 40, you can preserve their ovaries. For the adenocarcinomas, a little bit care we'll have to take. Like, we have to be very careful about their lymph node status, depth of stromal invasion, LVA size, and pathological grades. So if this is there, then we should avoid even. And if they're HPV independent tumors, we should not give them, we should not preserve their ovaries. Otherwise, ovarian preservation is found to be really safe for early stage cervical cancers. Now, adenocarcinoma cervix, yes, although the tumor is expressing ER and PR receptors, but there is no prognostic significance. Apart from that, we have to remember that MHT does not promote HPV replication in the lower genital tract. So we are safe if we are giving them hormones to both squamous and adenocarcinomas, although the limitation remains that evidence is really limited with us, but still it is considered safe. Now let us understand what should we do for the uterine cancer. A 42 years old woman presenting to us with stage 1 endometrioid adenocarcinoma, grade 1 disease. She undergoes surgery, but she comes to us back with moderate to severe hot flashes. And she also has dryness and dyspareunia. She was prescribed local moisturizers, but there was no relief in symptoms. So now she wants help. So how do you counsel her? And see, we are dealing now with a tumor which is ER/PR positive and actually hormone sensitive tumor, which is endometrioid adenocarcinoma. So we have to be very judicious when we have to give therapy to these patients. So it's not considered very safe. So endometrial cancer is not a contraindication of HRT, especially when the patient is stage 1 disease. So there's no much evidence available to suggest that there was an increased risk of recurrence. But it has to be understood that first 2 years, the risk of recurrence is very high in these patients. So we should avoid any kind of hormonal therapy in first 2 years at least. This way I'm talking about for the endometrioid carcinoma, which are well differentiated tumors, not a poorly differentiated or the poor high risk histologies. So giving HRD to these patients has not led to increased risk of recurrence if we are giving them after 2 years. So HRT as a whole may have little or no effect on the risk of endometrial cancer recurrence or development of new cancers like breast cancer for the women like our patient had, who has been surgically treated for an early stage endometrial cancer. However, the patients who have advanced stage disease like beyond FIGO 2 stage, the tumor is involving the cervix or is a high risk histologies or lymph nodes are involved. For these patients, the evidence to support safety of hormonal therapy is very, very limited. We do not have. So we should not give hormonal therapy to patients who are having advanced endometrial cancer or a serous endometrial cancer, a carcinosarcoma, or a patients who have where there is a doubt about their history like Lynch syndrome and all. So we should avoid giving hormonal therapy to these patients. A young patient's endometrioid carcinoma, well differentiated uterine confined disease. She has passed her surveillance, the intensive surveillance phase for 2 years and is really struggling hard, not responding to the non-hormonal therapy. We can consider, but we need to explain this to the patient. It's a hormone sensitive tumor. So risk of recurrence might be there, although not supported by evidence. So that all that kind of counseling needs to be done for these patients. So this is a meta-analysis which has very nicely suggested that there's no discernible effect of stage and type of HRT on recurrence. Sorry. Regarding this, but still it has been found that there can be occult metastatic cells, although it is not substantiated by the limited studies they have, which are available to us. But still, the recommendation remains the same as I've already explained, that the occult tumor cells, although they may not be hormone sensitive, but first 2 years we should avoid, and thereafter it is fine to give them. And we should avoid giving this in the high-risk tumors. Now, which preparation, oral versus vaginal? In normal postmenopausal females, estrogen replacement therapy, increase sequential therapies if we give, it is associated with increased risk of endometrial cancer. On the other hand, if we give them combined hormonal replacement therapy, it is not associated with increased risk of endometrial cancers. So NCCN guidelines suggest that estrogen replacement therapy is a reasonable option for HRT in low-risk endometrial cancer survivors. So vaginal route is considered to be very safe for these patients also, because it is bypassing the liver, and so it's considered quite safe for these patients. So this was a statement, it was given, and it has been found that SERMs may be an attractive option for patients with endometrial cancers, especially in smokers or those with a past history of breast cancers or stroke, etc. Only 2 retrospective studies have used HRT through different routes, and it has been found that recurrence of disease was seen only very few patients with oral, but vaginal recurrence, with vaginal route, there was none. So there's no analysis, actually, much analysis, not much evidence to support that vaginal is preferred over oral, but definitely vaginal is definitely very safe. Again, the minimum disease-free interval before any MHT started is still controversial, significant heterogeneity, but yes, most of the recurrences would happen within 2 years, so we should not start within 2 years. In which cases we should not give hormonal therapy if the tumors are, ER/PR positive, high-risk endometrial cancer, advanced stages, and unfavorable histologies, where we should not give, even sarcomas. So out of all the sarcomas, although the low-grade endometrial stromal sarcomas are the most estrogen-sensitive tumors, there it's absolutely contraindicated. But even if there are sarcomas, although they are not hormone-sensitive, but they express sometimes the RPR receptors and they're really aggressive tumors. So for sarcomas, HRT should be avoided. So this is the guideline summaries. I will not read through all the guidelines and all those things. We should remember, I've already told you that what exactly is the summary of all these guidelines, that we can give them after surgery only estrogen replacement therapy. We need to keep a watch on their breast issues. And also within 2 years, no. After 2 years, yes. Advanced tumors, no. Sarcomas, no. And the early stage disease, yes. Vaginal preferred over oral. Non-hormonal routes, definitely non-hormonal options better. Lifestyle intervention, definitely best. No doubt about it. Now let's come to breast cancer. A 52 years old, para 2, live 2, underwent right mastectomy and sentinel node mapping. She receives 3 cycles of chemotherapy and was started on tamoxifen because her tumor was ER/PR positive. Now, after 10 years, she presents to us with severe hot flashes and vaginal dryness. What treatment options? Hormonal versus non-hormonal. We know it was an ER/PR positive tumor. So in such patients, initial trial of non-hormonal therapies is considered better. The use of systemic hormonal therapy in survivors of breast cancer is generally not advised. The data is conflicting. Low-dose estrogen therapy remains an effective treatment option for genitourinary symptoms with minimal systemic absorption. The overall risk of new breast cancer event did not differ significantly between the women who were given a MHT versus non-MHT ones. And there's a significant increase in contralateral breast cancer in the MHT group versus non-MHT group. So in the breast cancer survivors, after MHT, is there an increased risk of recurrence? Yes, there was an increased risk of local recurrence. It was found that local recurrence, the breast recurrence will be high, but there was no significant increased risk of distal recurrences. So the patients who were not on not on tamoxifen therapy, the risk was higher, which can be considered because tamoxifen is a protective agent for them. So which kind of therapy we should give, sequential, estrogen only, or continuous combined? So there was no difference in risk across the main categories, but we can see there's a wide confidence interval implicating that small studies with limited statistical power and precision. So we do not have much, very robust evidence is not there. So what we can understand is for the breast cancer survivors without a uterus, after we can offer estrogen alone treatment and concomitant with tamoxifen use, initiating 24 months after the primary diagnosis for a maximum duration of 18 months. So first we should try the non-hormonal therapies and then hormonal therapies, that's for sure. And then we should tell them that there is evidence may be limited and so it may not be very useful for us. Just give me 1 sec, ma'am. Just one sec. कुछ अर्जेंट है क्या सपना जी? डिपार्टमेंट ऑफ ऑब्स्टेट्रिक्स एंड गायनेकोलॉजी डिपार्टमेंट है वो, हाँ ठीक। सॉरी मैम। Yeah. So now the two, three things are very important when your patient is on tamoxifen therapy. It has been found that the patients who were given the selective serotonin reuptake inhibitors, the SSRIs, their patients, there was an increased risk of death from breast cancer and death from any cause. So it is felt that these drugs like paroxetine, they would or fluoxetine or even the venlafaxine that is given, there is irreversible inhibition of this enzyme that is cyproterone P2AD6, and this reduces or abolishes the survival advantage conferred by long-term tamoxifen therapy in patients with breast cancer. So that's one important study that we need to remember. Regarding the non-hormonal therapies like healthy lifestyle, healthy diet, physical activity, maintaining a healthy weight, cessation of smoking. So these are the important factors. That is okay. Then alternative medicines, the phytoestrogens, because they are hormonal agents, we should not give them in the patients of breast cancer without, they are estrogens. So we have to be careful. Cognitive behavioral therapies like yoga, stress management, all these things are found useful. Acupuncture has been tried in some patients and has been found to be useful. Tibolone, phytoestrogens? No, actually, tibolone exerts an estrogenic effect on dormant occult breast cancer cells. Such drug would have a greater effect within the estrogen depleted tissues of aromatase inhibitor use. So we should not give tibolone to our patients. So there's no optimal duration established of the therapy. It is recommended that dose be gradually reduced in the event of discontinuing treatment. The withdrawal syndrome, although not frequent at the doses prescribed or hot flashes, is the main problem with short half-life agents such as venlafaxine and paroxetine. So we should avoid these things. Now let's talk about another cancer like the ovarian cancer. If your patient is 46 years old who undergoes the surgery and chemotherapy and her DEXA scan shows severe osteoporosis after ovarian cancer treatment, and now she wants to consider hormonal therapy for breast cancer. So can we give her hormonal therapy for breast cancer? Because ovarian cancer is actually a very aggressive tumor. It is the case fatality ratio is maximum. So is it safe to give? So it depends entirely on two things. One, the histopathology of your patient's tumor. For example, the high-grade serous tumors, which is the most common type of ovarian cancer, it is not hormone responsive. So you can give even hormonal therapy to these patients. On the other hand, the younger patients often suffer from low-grade serous cancers, clear cell cancers. So these tumors are hormone responsive. So we should avoid giving hormonal therapy to these patients. Rather, these patients are kept on anti-estrogenic therapy. So we should avoid that. So that's one very important point that is we have to remember when we are prescribing therapies to ovarian cancer survivors. So this is the data from various studies, so I will not go in this. But yes, definitely for bone health, the hormonal therapy was considered very, very safe and effective for the patients with high-grade serous ovarian cancers. So it was found that the granulosa cell tumor is another tumor where we should not give hormonal replacement therapy because it is again a hormone-sensitive tumor. For the germ cell tumors, the survivors of germ cell tumors, where you have already, if at all is advanced tumor and you've already removed their ovaries, then you can definitely safely consider this therapy. So this is what is I wanted to say. Vaginal therapies you can offer to any of them because it is relatively safer for all. But for granulosa cell tumor, no hormonal therapy at all. That is contraindicated totally. So best regime will be estrogen replacement therapy. The patients who have already undergone surgical therapy, for them estrogen is good enough. But the patients who have their uterus intact, you can give them progesterone addition beyond estrogens. And the combined patients, definitely we need to keep the breast surveillance. That is very important. So younger patients with germ cell tumor, I've already told you, we should give them. There is no problem in giving them. It is safe for them, for germ cell tumors. In which variants of CA ovary HRT should not be given. HRT should not be given, avoided in patients who have endometrioid carcinoma of ovaries, low-grade serous carcinomas of ovaries, and also for clear cell carcinomas, and also for the granulosa cell tumors. So where these tumors are relatively rare, often affect younger women. Right. So for them, requirement is really high, but we have to understand because they are type 1 tumors, which are hormone responsive often. So we should be very careful when we're planning a therapy for these tumors. So we should avoid hormonal therapy for these patients. So to take home message, ovarian, sorry, ma'am. Survivors of epithelial ovarian cancer may consider the use, but the patients who have advanced serous and endometrioid and sex cord stromal tumor should avoid that. That is all for the ovarian cancers. Now, often there is a situation when ovarian cancer survivor, her family is having the BRCA positive tumors, and CA breast is there is a history of CA breast in mother, Masi, and patient is undergoing her salpingophorectomy. You are doing it is reducing salpingophorectomy for these patients, or even mastectomy and breast reconstructions. So, what should we do with respect to hormonal therapy for these patients? So, it's really very tricky to give hormonal therapy for these patients because we know that for ovarian cancer, fine, she's safe, but she already has a history of breast cancer, already undergone a mastectomy. So can we have an increased risk of, potentiating the occult malignancies in these patients? So decision making becomes very difficult. We need to really talk to the patient, explain them that the evidence is very less, and breast cancer may be associated with an increased risk of having a disease because of the hormonal therapy. So you can give them vaginal preparations for sure, there's no problem, but then be careful regarding their surveillance. So that's what it is. Although one study said that only one study was there who said that there was an increased risk, but some studies say there's no risk. So there's really a conflicting evidence. So in mutation carriers, it is really very less data. So what is done nowadays is, like, this is being again under evaluation. The studies that they do a two-step procedure for the salpingophorectomy. First step they will do a salpingectomy, and the next step they will do a oophorectomy in young patients at 35, because fallopian tube is the cause of the problem. So first they remove the fallopian tube, in the next sitting laparoscopically you can remove the second ovary. But then this final data is yet to come, but this is considered a very good approach for that. So I think with that, I think it's my time is over, ma'am. So I will just briefly explain one or two things if my time is over.
I think so.
Sorry, ma'am.
Shobha,
It's over, right,
I
ma'am?
think so. Shobha, are you there? It's,
Very much here, ma'am.
if you
Very
are just
much
few
here.
more slides, you can continue. Few more slides, you can continue.
I just wanted, I had one request of Seema. Of course, that was a brilliant exposition of MHT. I just want to, just emphasize that cancer survivors, when they come to a menopause clinic or to a gynecologist, what are the alert symptoms that we should look for, which will tell us, because menopausal symptoms we are very adept with. But what about the recurrence, and when we should refer them back to the onco clinic? I was looking forward to some such signals from you, so that we can, yeah.
Ma'am, see, signals means
Yeah.
the patient who's
That is
coming
okay,
to you.
and then you can wind up, please.
So it's fine, ma'am. So the thing is, ma'am, that patient who is a cancer survivor is supposed to be following the oncologist per se, her recurrence risk and her recurrent symptoms. She is not supposed to quit the usual surveillance that is supposed to be there. So for each cancer, there is a definitive protocol for them to follow. So like first 2 years, they have to look into, when they come to us, like every cancer, it is a very different protocol. For example, for CA cervix, CA endometrium, we ask the symptoms related to excessive vaginal bleeding, discharge, loss of weight, undue abdominal pain, pelvic pain, backache, loss of weight, loss of appetite, any alteration in bowel habits, bladder habits, any such kind of symptoms. And then examination, if you find there is a growth, there is a mass, there is abnormal thickening, right? So, or PR examination, staining, all these factors. A thorough pelvic examination, abdominal, general examination, then we advise them imaging. So that oncological surveillance is supposed to be continued for rest of their lives. That's very important.
Yes, I understand that.
So,
my
yes.
only concern was this, that if the woman is put on MHT, whichever cancer it be, does this surveillance change in any way?
No
is
way.
there a modified protocol?
No, ma'am.
That's what I want, because that is what
She means
gynecologists
more
will worry.
frequently she has to go. Yeah.
No, we don't have to change the protocol at all.
Okay.
If
Right.
during the protocol, for example, when we are following the cervical cancer survivors, our patients, so the protocol respect to disease remains totally same, and we additionally add measures to improve their sexual dysfunctions, to improve their bone health. So these are additional sources, ma'am, but they are not replacement of their surveillance protocols at all, ma'am. Yes,
But our follow-up of MHT should continue. That is a
yes,
different
ma'am.
track.
Sure, ma'am.
Okay, that
There's
we
no
have to
harm
continue.
because yes, ma'am. Absolutely, ma'am.
Yeah.
Yes.
Really
Thank
an
you,
excellent,
Seema.
informative talk,
Yeah.
Seema. I wish, Soba, we can prepare a chart like a tabular column, like that is type of cancer. HRT should not be given. HRT can be given.
Yes,
Type and route. So we can prepare a chart like that. It will be a ready reckoner for the practitioners.
Yes,
I
ma'am.
think
We'll
at least
include it in the handbook, ma'am,
evidence-based things.
in this module. we'll do that.
Yeah, yeah.
Thank you very much.
Not
Yeah.
a debated
Please take
one.
it forward.
The clear-cut prescription, we can really prepare that. Okay. Thank you. Thank you. It's really a wonderful talk.
Thank you, ma'am.
Lovely talk, Seema. Excellent. I love the way you've sort of given references with articles, research articles for each and every cancer. That was very lovely. And when you think about it, for ovarian cancer,
Your
high
voice is
serous,
very low.
in
Please
ovarian cancer, okay, in ovarian cancer, is it clear now, Anita?
Yes,
Come
yes.
little closer to the mic.
See the problem, there's a problem with my desktop. I got an external mic today, but my unfortunately it is not working. So I've shifted to the mobile now, and it is completely, I mean, the highest volume possible on the mobile. Okay, Seema, just when you're talking about ovarian cancer, we think that whenever there is a high grade serous lesion, you would not even think of prescribing MST. But conversely, in ovarian cancer, a high grade serous you can prescribe, whereas a low grade serous you cannot prescribe. That is something like an opposite situation, right? And again, in endometrial cancer, giving vaginal therapy is safer. That again makes it a little dicey for the simple reason you know that the vaginal estrogen is so close to the pelvis. But
Yeah,
it is safe. So these two
better than oral.
contradictions,
Yeah.
these two contradictions make it a little difficult to understand, but I'm sure it is evidence based.
Ma'am, evidence
And
are
one more
really
thing,
very conflicting. Very less evidence on routes. Ma'am, there's no randomization. There's no level of an evidence available to compare the routes. But when these patients have genitourinary atrophy, all those symptoms, then we can give that for some short span of time that works for them. And but I told you, ma'am, for endometrioid cancer, first 2 years, do not give hormones
Yeah.
at all. Because these first 2 years, the risk of recurrence is really high, ma'am, for them. So thereafter, based on their requirements, and if they do not respond to the non-hormonal therapies, then we can consider for short time. So I have already told you that, ma'am, that advanced tumors we should not give, ma'am, and the serious tumors we should not give. There's no evidence to support that. Yes, ma'am.
one more thing is about venlafaxine and desvenlafaxine. Both of them can be given in breast cancer survivors because they do not affect the incidence of recurrence. And then and one more thing is they can be given with tamoxifen, whereas fluoxetine and paroxetine cannot be given with tamoxifen, like you mentioned,
Yes, ma'am.
because the efficacy of tamoxifen cannot be metabolized into its end metabolites. That's
Yes.
the reason we don't give it on. But for venlafaxine and desvenlafaxine, that doesn't hold true.
Jyotika, shall we discuss after the next session?
Yeah, I think it's a better idea, Lambuja.
Yeah,
After
because
your
it is the same topic. I don't know, by mistake, Shobha has given MHT to Seema also. My talk has made very easy. Although her talk is about the
No, madam. No,
survivors.
I have not given MHT. I had just requested her that,
You asked
you
her for
discuss
care of
about
the
survivors.
survivors.
Yeah,
She
correct,
talked about
correct.
the MHT.
Yes, yes.
I
So
want
she
to
thought
reduce all the
perhaps we need
things.
insight into that. It's okay, madam. It's okay. It's
It's
okay.
okay. That's all.
Yeah,
It's a
your
wonderful,
perspective will be
wonderful talk by
menopause
Seema.
practitioner's perspective. Yes, ma'am.
Yeah,
Yeah, please go ahead.
wonderful talk.
Let us learn more from you, Ambuja.
You know, see, nobody can stand in near Seema Singhal, who is a professor of AIMS, and she did such a wonderful work. Nobody can talk in front of her. Such a wonderful point she brought about.
Yeah, she did an excellent job. Very good. Can we have Dr. Ambuja's CV, please?
Yeah. Paresh, please share Dr. Ambuja's madam's CV, no? So
Is it
Dr. Jyotika
necessary?
Desai can introduce.
Is it necessary, Jyotika? You just tell my name, that's enough. Instead
Ma'am,
of
your
Jyotika
name is
saying all these
everyone
things.
From
knows.
that side. So the name is already known.
Yes. Thank you,
Madam
Paresh.
is Queen Elizabeth of IMS. When we had
Oh.
done digital installation of Ambuja Madam, we had made Madam as Queen Elizabeth.
Wow. Now we should make a Rani of some Indian kingdom, actually.
Thank you, thank you, thank you. Grandma of IMS.
A very helpful person. Very helpful.
So shall I start?
Yeah, Ambuja.
Yeah.
Yeah. See, somebody is sharing. If you don't share, then I will start sharing.
कोई नहीं share कर रहा है. No, nobody is sharing.
Nobody is sharing.
Ma'am, आप share करिए. You please share now, ma'am. I think the net is slightly slow, so you were seeing the slide. Now you share, madam. Yeah.
Are you able to see my slides?
Yes,
Yes,
right,
yes.
Ambuja. Yeah, perfect.
Good evening, everybody. All the respected seniors, dear colleagues, and friends. I am really thankful to Dr. Seema, who wonderfully dealt with the MHT. And my job is made very easy. I can skip some of the things which already enumerated. Let me begin today not with the statistics, not with the guidance, but with a patient of mine. Her job I'm going to take now as the care for the cancer survivors. My patient was 46 years old, a breast cancer survivor. She has finished surgery, chemotherapy, radiation. Her report says no evidence of
Your
disease.
slide is not changing.
No slide for this.
Acha, okay.
Everyone said, you are very lucky and you are a good fighter, you have won, and so on, so on, everything. But when she came to our clinic, she whispered, Doctor, I haven't slept for months. I am drenched in sweat at night. My joints hurt. My mood is broken. My marriage is strained. I don't recognize myself anymore. She survived cancer, but is she really living? And any patient who takes treatment for the cancer anywhere in the body, either chemotherapy, radiotherapy, or surgery, all the changes and estrogen deficiency will come immediately, not after 2 years. So we need to attend her. We should not say that, no, you bear it. Nothing will happen. Don't take hormones. That should not be the question. Until now, for decades, what we were concentrating was what is the survival rate, 5 year survival rate after cancer? How are we going to prevent recurrence and cure of the cancer and all? And this part we have done remarkably well. Today, millions of women are living years and decades after cancer. But now a new question, it will stand before us. Is survival enough? Or do our survivors deserve a life of comfort, dignity, and well being? Menopause after cancer, I told you, it is sudden, severe, and surgically, most of the time, surgically operated and emotionally devastating. And menopause hormone therapy has become one of the most controversial, misunderstood, and feared topics in cancer survivorship. So, today we will discuss when is it safe, when is it risky, for whom it can be given, in which cancers, in what form, under what supervision. Because evidence, not fear, must guide our practice. It is a very sensitive subject when the patient, because India definitely they are not coming out with any problems. It is about moving from can she survive to can she live well. Every time a new solution is discovered, you know what thing feeling comes? How infinite are boundaries of ignorance. This is like a small drop in the ocean. That's what is the things that's going on. First of all, we should think why this topic matters to us. Treating a cancer survivor, or what happens to, is it MHT in the country? 15 million cancer survivors are there worldwide. India, substantial rise since about 40 years back, how it was, because of the age of menopause is increasing, age of, longevity is increasing. When at the time of 47, 48, it was only 35. Now it has come to 75, 80. So there is 26% increase in all the cancers because of the age also. 1 in 9 will develop cancer in future, and up to 80%
Madam,
develop premature menopause. Yes, you are able to see my slides or not? Hello?
hello,
Hello, Shobha, are you able to see my slides?
Madam, can
We
you
can
share?
see.
Hello?
Okay.
Are
Revati
you able?
Madam, is it
The
seen well?
slides are seen, Ambuja.
Yeah, I
Okay.
can see. I can
Okay,
see.
okay. Okay,
Nicely
okay.
seen.
My
Why
net
this
is
topic
slow.
matters?
Okay, okay.
Okay.
Uh, is there any problem? Shall I go back and come again?
No. Continue, Ambuja. Continue.
No, madam, we
Are
can
you
see
able to
slides.
see, Ritika?
Yes,
Yeah,
madam.
Madam, my
continue.
net is slow. It is seen,
Yeah,
madam. My net is slow.
yeah,
Yes,
It
yeah.
is all
madam.
seen. Yeah.
Seen.
Up to 80% of the people, as already Seema told, they'll go in for the premature menopause. That's what is the problem. And along with that associated, we know vasomotor symptoms, GSM, osteoporosis, CV risk, many are young, and quality of life is not equal to luxury. Giving MHT is not a luxury, it is a survivorship care. Science has increased the lifespan by 50%. It is the health span that is more important than the lifespan. See, actually, in this 40 years, the breast cancer has become the most important one, where 24% of the people are suffering with the breast cancer, and remaining all are following. Next is the colorectal. They will never come to us, colorectal and breast also, most of the times. Nowadays, because of the increased awareness and all, they are coming. Otherwise, they all will go to the general surgeons. That's why we are not aware of it. But next comes is the cancer cervix and the cancer uterus. Actually, the cancer cervix has come down because of the gynecologist, lot of efforts that is being done, taking the pap smears and awareness programs that is being conducted. So already it is being dealt with. Seema, she told what is the previously, before our WHS study, the blanket rule was for everybody menopause means it is the estrogen for all. Now it has changed from the habits trial, that is the hormone replacement after the breast. Is it safe? The trial that showed that breast cancer recurrence has increased because of the hormone therapy. And because estrogens feed cancer, there is a blanket ban from then onwards. Though the Stockholm trial, which is little less, a short one, but never we can do the randomized controlled trials like WHA. Stockholm trial showed it is a conflicting data. But what our WHA trial showed, it showed estrogen only wing will not raise the incidence of cancer, but the both estrogen and progesterone will raise the cancer. Decreases after stopping the MHT. The risk of breast cancer is dose and duration dependent. That's what is the thing that informs. So the result is what happened. Shift from prohibition means not completely banned. It went to the personalization. That was what happened. So the golden rule, what is the golden rule? MHT is generally avoided in hormone dependent cancers, but may be considered in selective non-hormone dependent cancer after proper assessment. So decision must be individualized, multidisciplinary, shared with the patient. That's what is very important. Updated evidence-based medicine should be there, and it should be ethical practice, and there should be human care must be present. Anytime a cancer means when you're using the MHT, use with caution. What do you mean by caution? Always remember, whenever you give estrogens, it promotes cell proliferation wherever in the body. It inhibits apoptosis, activates estrogen receptors and progesterone receptors. But not all the cancers are hormone driven. Now I'm referring more about the breast cancer and uterine cancer because all the other things are little less. So MHT is the cancer surveillance where it can be given and where it need not be. Revati, you are asking this question, no? So the blanket rule, it can be used in the cervical cancer, yes. Vulval and vaginal cancer, yes. Borderline ovarian and germ cell tumors, definitely we can use it. But avoid in breast cancer, uterine sarcoma, low-grade ovarian serous carcinoma, and clear cell carcinoma and sex steroid carcinoma. I'll explain all these things again. So hormone dependency spectrum we should do. Why we should know is after surgery, we are going to give some endocrine things like tamoxifen or aromatase inhibitors. So in which cases they are useful and which cases will be more aggressive and these will not help. So strong ER positive is the breast and type 1 endometrium, where definitely we can give the anti-hormones, that is anti-estrogens and endocrine, highly effective it will be. But in moderate, it's a partially effective. But the third one comes, that is the triple negative, where ER negative, PR negative, and HE Earth negative. These things are present. This is very, very important because no drug is going to act for this. And it is an aggressive tumor, and that is the problem. Recently, even one of our colleague, she died of cancer endometrium because she had a triple negative form. So let us see what the evidence says, and we'll analyze cancer-wise. When we are discussing about the breast cancer, there are three things that are there. One, ductal carcinoma in situ, that is ER positive, PR positive, or ER positive and PR negative. And second thing is the family history, already our Seema told, and BRCA positive and family history of BRCA, cancer is present where she is BRCA positive, or family history is there, but she is not, BRCA is not present. In that case, are we going to give the MHT or not? And very young age where you do operate premature menopause, what are we going to do it? Yeah. Because of the habitus trial, I already told you, it showed that if you give MHT to DCIS, that is the ductal carcinoma in situ, where ER/PR positive is present, there is a recurrence risk is increased. But even if it is ER/PR negative also, this is not going to act. It is going to estrogens or going to stimulate a remnants. Even if it is present, it's going to stimulate the cells that are present. That is why the blanket rule, don't use MHT in breast cancer. But what about the local estrogens for the GSM and all? Yes, systemic absorption is minimal. And studies show no clear recurrence or signal. but still it is controversial. That black mark is present. Only recently I read somewhere that that black mark is removed, saying that we can use it, but still it has not come to our notice yet. The guidelines are not released. Only after failure of non-hormonal therapy, with oncologist consent and mutual consent with the patient, we should use the local estrogens also. And special scenarios, I already told you, young BRCA carrier, where we will do the when patient underwent bilateral salpingopectomy at the age of 35 years, what to do for that. But she is not suffering with the cancer. We can give MHT till natural menopause. What is this BRCA? BRCA is a gene, that is breast cancer gene, that prevents proliferation of the cancer cells. When this BRCA gene mutation occurs, the proliferation of the cells will take. Means her sister or somebody in the family, they are having the early, there's a genetic ovarian and breast cancer syndrome that is present. But as it is, she is not a patient. That time definitely we can use the things. And premature ovarian failure, because of the chemotherapy, we can use. Patient on tamoxifen, already Jyotika told, it is these patients when estrogen receptors are positive, you better avoid the paroxetine and fluoxetine for these patients. I'll tell you the explanation. Are we doing estrogen receptor and progesterone receptor for all? Of course, not not in every where they are doing. Maybe in AIMS for every patient they are doing. But in Hyderabad, all the general hospitals, they don't do it. Private only they do. ERPR testing should be done on core biopsy at the initial sitting for all invasive breast cancers and ductal carcinoma in situ before starting the treatment. In clinical practice, roughly 7 to 8 of every 10 breast cancers are ER positive, means 80% of the people are ER positive. That's why you should be careful where MHT is contraindicated. What about the genetic profile? Are we doing for everybody? Means genetic testing can reveal if a woman has genetic variations linked to an increased risk of certain conditions. So for this one, it will decide. There are 5 important things are there for genetic testing, how it will be useful. First, it will tell estrogen metabolism genes like CYP1A1 and COMET, which decide whether estrogen processed properly or not. The second, hormone receptor genes, all of us know that is the estrogen receptor 1 and 2 or progesterone receptors, to determine whether the sensitivity of the tissues to hormones. And the next is the drug metabolism genes like CYP2D6, which influences how the body handles the hormones and SERMs. And fifth is the cancer predisposition genes such as BRCA1 and BRCA2, which guide caution in symptomatic MHT. After DCIS, survival is excellent. Symptom control is important, non-hormonal for VMS. Safety comes first. Decision must be individualized. Adjuvant endocrine therapy, that is the tamoxifen, reduces the risk of breast cancer recurrence. So we can say ER positive, avoid MHT. ER negative, that is estrogen receptor negative cancer, use with caution. And for that, use alternatives if it is a positive. That is the SSRI, SNRI, and physiologicant. I think it's very clear now whether to do the ER estrogen receptivity or not. One. Second, genetic counseling, is it necessary or not? And what the blanket rule, whether if it is a ER positive, please don't use FHT, ER negative with caution. But what the statistics shows is even in ER negative, it's only 20% of the people. A small number of cells will be stimulated by the estrogen and recurrence is there. That is why, as a blanket rule, after the studies, they said if it is a breast cancer, don't use estrogens. And first line for a thing already, there's the lifestyle modification and all are there. Heart pressures, SSRI and SNRI. That is good, but avoid paroxetine with tamoxifen. Why? The tamoxifen itself is a prodrug. It's not directly acting. It kills the cancer cells. It is activated in the liver to endoxifen and through an enzyme called the CYP2D6. And paroxetine is a strong against for CYP26. That is why if you give paroxetine, the effective treatment will not be there because of the tamoxifen that will not act. That's why it is contraindicated. So you have to give venlafaxine or desvenlafaxine. That's the first choice we have to use it in this case. And second situation is the one the survivors they suffer a lot with the GSM sexual problems and all. So can we use DHEA for that one? Any alternative medicine is there other than estrogens? Everybody may not be willing to use. They say the minute you say cancer breast and use the estrogens, they may not like it even though we tell them. So the first line therapy is non-hormonal preparations which are safe but have limited efficacy. DHEA locally has been used in breast cancers on aromatase inhibitors. I will tell you when to use aromatase inhibitors with a dose of 6.5 milligrams of DHEA every 48 hours for 6 months. GSM improved and serum estradiol did not increase. So DHEA locally we can practice. And ospemifene is the one drug which is orally active. So it also has been used with no increase in the incidence of recurrence. Is progesterone necessary? That's another question for us because we have removed the breast but not removed the uterus. Still it is there. So NAM's position statement in 2020 says low dose vaginal estrogens, vaginal DHEA and ospemifene, effective treatment for moderate to severe GSM. It is administered. Progesterone is not. We cannot guarantee the endometrial safety. However, we need to examine the patient every 1 year. Only the treatment is advised only up to 1 year. But what our International Menopause Society says, unless there are symptoms, asymptomatic patient, there is no need for the endometrial surveillance for this. So no need to add the progesterone for the patient. And one more wonder drug that is available now is fezolinetant, that is neurokinin 3 receptor antagonist. It is a very good one and it is a FDA approved in 2023. It is a non-hormonal, targets hypothalamic thermoregulation and at the dose of 45 milligrams tablet 1 per day for 12 months. There are minimal side effects for women who can't or don't want to take HRT. This is very good. Only thing is liver monitoring for 3 months, every 3 months is very important for this. The second one is elinzanetant, because we are not using these two drugs, but still, if not today, it will come tomorrow. This is again, if the patient is having insomnia, not able to sleep because of these problems, this is a very good drug. It does not raise estradiol, progesterone, or FSH levels. So these two are the drugs which are promising to use it. So if you use this NK3 antagonists are particularly useful in survivors of hormone-dependent cancers. It can be used in ER positive breast cancer, endometrial cancer, ovarian, cervical, vulval, vaginal, everywhere you can use. They do not stimulate estrogen or progesterone receptors. So these are the future drugs, but we have to try and see. What about the after treatment when we are giving the endocrine therapy like tamoxifen and aromatase inhibitors? What about the MHT? Can we use these things or not? And when we can use these things? Tamoxifen is a selective estrogen receptor modulator. It prevents recurrence of the breast cancer. It blocks estrogen receptors in breast tissue, prevents estrogens from stimulating the cancer cells. And all of us know about the aromatase inhibitors, that is the letrozole, anastrozole, and exemptistane. They block aromatase enzyme, so stop peripheral conversion of androgens to estrogens. The tamoxifen, it blocks receptors, but this one conversion is and aromatase inverters, they prevent conversion. Result, very low estrogen levels in the postmenopausal women. How to decide whether to give tamoxifen or aromatase inhibitors? These things to be given only for the ER and PR positive patients. If it is negative, it is not going to act because they are all aggressive tumors. This is not going to help. It is not useful for the triple negative or the ER/PR negative cancers. Tamoxifen is given premenopausal and perimenopausal women. Aromatase inhibitors are preferred in the postmenopausal women. High-risk premenopausal women need ovarian suppression, and tamoxifen or nowadays people are giving combined both tamoxifen and letrozole also. Tamoxifen 25 milligrams for 2 to 5 years, then letrozole 2.5 milligrams for 3 to 5 years. In ER positive breast cancer survivors, systemic MHT is contraindicated. Manage menopausal symptoms with non-hormonal therapies and avoid CYP2D6 inhibitors with tamoxifen. That is the final answer. So what about tibolone? In the beginning, before the Liberate study was done, we were thinking this is the J. He can use for any case, even for the breast cancers, we can use it. But Liberate study, the trials, when it came out that time, I think we came to Surat only, Dr. Anita, when the Liberate trial results were there. At that time, it was clearly said that because of the recurrence rate, which is more, we should not prescribe in the breast cancer survivors. It should not be used. So, algorithm, how are we going to do it? Ductal carcinoma in situ survivor, menopause symptoms if it is present, assess severity whether it is mild, moderate, or severe, and start with a non hormonal therapy. Check ER/PR status. If ER positive, avoid MHT. But we can use vaginal estrogens if necessary, but regular monitoring is necessary. If it is ER negative, consider MHT. Selection is very, very important. All the indications, contraindications are the same for MHT when you are using for other general cases. Yeah. This one, this already discussed young BRCA carrier where BSO is done at 35 years, but she is no cancer rate. Do we give hormones or not? Yes, we can give MHT till natural menopause because she is not having any cancer. No, a non-hormone dependent cancer, yes, it is a strong indication. We can go ahead with the things. Whom are we going to test for BRCA? Not for all, no. Like ER/PR, for every cancer patient, we are telling only in the indicated ones where high risk patients only we are going to do the BRCA and we are going to do the prophylactic BSO or salpingo-oophorectomy, we are going to do it. Or premature ovarian failure for any other chemotherapy, we are doing. So hormone therapy in genetically or familially high risk women, if they come, what are we going to do? Family history present, but she's a non-BRCA. Somebody would have had her sister or somebody, but she herself is not a cancer patient and no BRCA positive. That is, it is not an absolute contraindication. Risk benefit assessment is the key. We can use MHT. And if it is BRCA mutation carrier, if it is there, after risk reducing BSO, estrogen alone MHT is acceptable and may be protective. Estrogen, progesterone, both estrogen and progesterone may increase the risk, but evidence is limited. No randomized control trials are being done. And survival of ER positive one don't give MHT. So it's very clear. If she is not suffering with the cancer, even though it is a family history is there, we can proceed with that one. BRCA carrier, not sufferer with the cancer, we can give estrogens, but not estrogen and progesterone. And if she is a estrogen receptor positive and BRCA positive, it is a contraindication. Don't give any things, but all these things with the mutual consent only. So breast cancer survival pearls. MHT in breast cancer survival, systemic MHT contraindicated in ER positive. Avoid estrogen with tamoxifen and aromatase inhibitors. Avoid CYP2D6 inhibitors with tamoxifen. Use non-hormonal options first. GSM vaginal estrogens with oncologist consent. Protect bone in or aromatase inhibitor users. What about endometrial cancer? He's already dealt a lot. And type 1 estrogen dependent, no. Type 2 serous and clear cell, no. I'm not going into the details. What about ovarian cancers? This also depends on the histology, that is high grade serous. Yes, we can give, very safe. It is not a hormone dependent. But endometrioid, clear cell with caution. Granulosa cell, it is a avoid MHT. Cervical cancer, already she told, it is the squamous cell carcinoma and adenocarcinoma. It is very safe. Adenocarcinoma with safety precautions. Most cervical cancers are not hormone dependent, and others, it is safe. Colon cancer, lung, thyroid, lymphoma, melanoma. No evidence of recurrence after the MHT, all these things. So we can do it very safely. Or vaginal and vulval cancers hormone dependent? That's again another question. Most vaginal and vulval cancers are squamous cell carcinomas or similar non-hormone driven tumors. They do not depend on estrogen for growth. Clinical but we have to consider, like already I told you, like any other hormones, when we are doing complete checkup, that is already our Sima told how we have to examine the patient from top to bottom. If there is indications, contraindications, like any general person, we have to do it. Multidisciplinary discussion with gynecologic oncologist and menopause specialist is recommended before starting the systemic MHT. Timing hypothesis, the same. Start within 10 years, and after 60 years, it's only extended. For any hormone which you are giving, you have to take mutual consent is very important. But the trick only we should think is, whenever we do the surgical procedures, the symptoms will come immediately. So we can't wait for 2 years to start with the hormones. So first try with the non-hormonal, and then if it is not controlled with the mutual consent under ethical procedures, we can give the things. Route and regime of prefer transdermal in survivors always. Practically algorithm, that is identify cancer type, check hormone sensitivity, assess stage, recurrence, and risk, try non-hormonal options first, discuss with oncologists, document shared decision. In India, we have certain, just 2-3 minutes. Fear of litigation, over restriction, poor counseling is there. Documentation is very, very important, and take a written consent. Take home, not all cancer survivors are barred from MHT. Breast and glandular cells, no. Ovarian, serous, cervix, they are all yes. Quality of life is part of cancer care. Decision must be shared. So to conclude, true spirit of healing should be there. Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani paschantu, ma kaschit dukh bhag bhavet. Means, may all be happy, may all be free from illness, may all see goodness, and may none suffer. That should be the motto of the gynecologist before treating any cancer survivors. So I thank all of you for giving me the opportunity to talk about this. Thanks, Shobha. Thanks,
Thank you.
Anita. And thanks,
Thank you,
Raj,
madam.
and all the others. Thank you very much.
Thank you.
Madam, please
It
explain
was a
endometrial cancer
wonderful
and HRT.
presentation.
I'm not able to hear Anita.
Madam, it was
Yeah,
wonderful
Bina,
presentation.
shall I, in that some explanation is there, and
Very
then
unique. You covered everything such nicely, madam.
Thank
Hats
you,
off to you,
Anita.
madam.
it was
Thank
really wonderful. It was really wonderful. Yeah.
But so much of overlap because Sima has done
Overlap
a
is there.
wonderful
Yeah.
job of
Overlap is
presenting.
there.
Yeah,
Correct. I understand that, I had wanted slightly different context, but anyway, it has helped us a lot.
no problem.
Both the presentations have helped us a lot. Can I request the chairpersons now whether I can share my slide?
Yeah. Excellent talk, both of you. And I was just waiting. The non-gynecological cancer survivors also require
Yes,
MSG
madam.
because
Yes.
recently I had a patient who got operated for papillary carcinoma thyroid, and she was my own patient. So she then subsequently she had a good reproductive cycle, delivered 2 children, and post-menopausally she came with hot flushes. And she had been to some other doctor, and they said that no, you had a cancer, no MSG at all. So they refused to give her. So many a times the practitioners they want to play safe, and they don't want to give MSG at all for a patient for any type of cancer survivor. So learning and knowing these things is a must. I wish this prescription writing webinar is going to be very, very useful for all the audience. Very nice.
Thank you, madam.
Yeah. Thank you.
Yeah.
Can you hear me? Shobha, can you hear me now?
Yes, of course we can hear you. Yeah.
Thank you, Ambuja. That was really excellent. We had 2 excellent talks today. We are really lucky. And one more thing is about aromatase inhibitors. The woman is on aromatase inhibitors. It is better that we don't give her estrogen. Whereas if she is on tamoxifen, still it is safer. We can give her estrogen. So that is the take home, that we should not give her estrogen when the patient is on aromatase inhibitors.
Yeah.
Thank you so much, Ambuja. I think we can go to Shobha's now.
Jyotika.
Can I share my slides because time is less? With the
You can.
permission of the chairpersons, because
Certainly.
is my screen visible?
Think, Shobha?
Yeah, we can
Yes.
see.
Properly, because we are testing my mic again. Can you hear me properly?
Yes, we can hear you. Yeah.
Thank you so much. Thank you so much.
No, is my screen visible? Anybody?
Yes, Shobha, you can start.
I can start? Okay. 1 minute.
Make full screen, Shobha.
Yeah, I made. So thank you very much to everyone, and especially to the 2 speakers, to the 2 chairpersons, and also to the president and secretary, because today I have a small sense of achievement that at least this topic has come up for discussion, and everybody has now been bold enough to concede that even in the face of cancer, our women require a very high quality of life because they have battled cancer, and now we should give them the best that this scientific research has to offer. So I think we are being on the same page. It will not be difficult for us to adapt to this kind of treatment. I should proceed now with the slides, which are actually a summarization of the previous two talks. Okay. So, yeah. So then, 1 minute. Yeah. So let me begin with breast cancer survivors. Is there need for MHT? Yes, we all agree that there is need. They often experience early menopause due to the chemotherapy. Sometimes they would have had bilateral oophorectomy as a prophylaxis or something. They will have vasomotor symptoms due to the tamoxifen therapy also. 80% of them have. Aromatase inhibitors may also cause hot flashes, but they tend to be less frequent and they tend to be less severe. Now, in women with history of breast cancer, systemic estrogen therapies are considered contraindicated. Forget the relatively, they are contraindicated as the evidence stands now. So when we talk about MHT for breast cancer survivors, every gynecologist will feel, why are they talking at all? Because MHT is a standard contraindication for women with a history, personal history of breast cancer, not family history definitely, but personal history. So it stands today by evidence that systemic MHT with estrogen is contraindicated in women with breast cancer. And this is very well evidenced by the habits trial, which Ambuja Madam estrogen still can be used when there is a strong indication for relief of vaginal atrophy symptoms in these women. So do not recommend estrogen for women with a personal history of breast cancer. Receptor status is very secondary, I must say. As of now, we are not recommending systemic estrogen for women with personal history of breast cancer. And then we must look at other methods of controlling symptoms or preventing osteoporosis should be utilized in these women. It is not only the relief of vasomotor symptoms, but we must have the standard preventive strategy for preventing osteoporosis in these women also. The principles and approach to treating women with breast cancer with hot flashes will be the non-hormonal therapies, the SSRIs and the SNRIs, all centrally acting drugs, and they will be similar in women taking tamoxifen compared with those who are not taking tamoxifen. The efficacy of the hormone which we are using will be the same. What happens to tamoxifen efficacy in preventing recurrence? That is what becomes a question, because some of the SSRIs, as already told by both speakers and the chairpersons, may inhibit the conversion of tamoxifen to endoxifen, which is the active metabolite of tamoxifen, which is constantly acting to prevent recurrence in breast cancer. And because it is in these SSRIs, co-administration can inhibit the CYP2D6 enzyme, okay, which will clear off this tamoxifen before it gets converted to endoxifen. And therefore, paroxetine should not be used. Those who do not interfere should be used, and they are the citalopram. That is the largest experience is with venlafaxine. I have put in some dosage because if it is because since this is prescription writing, the citalopram 10 milligram per day, venlafaxine 37.5 milligram per day to begin with, desvenlafaxine 50 to 100. Escitalopram seems to be a very favored drug amongst practitioners, I must say, because it is used for a wide variety of symptoms. And therefore, escitalopram, maybe the field experience with escitalopram is very, very high. And therefore, we can consider that also. All right. So in these women, now some women will have specifically hot flashes at night. So in them, we can use graded doses of gabapentin to begin with. And if they require more than that, then we can consider the SNRI. Okay,
Shobha,
so we
desvenlafaxine is anxiolytic. This can be used if there is any problem, sleeplessness, anything like that in the night, which both of them are very safe compared to gabapentin.
Okay, madam, point to be noted. So now this is a class of drugs which is fast emerging, and it has got a lot of promise. I think it has become recently available in India also, and will soon be available probably for our treatment. And this is the neurokinin B receptor antagonist. As Madam already said, they act extremely well at the level of the hypothalamus in the thermoregulatory center, and specifically reduce the vasomotor symptoms by this central action. And therefore, we must keep our eyes and ears out for this particular drug, which is fezolinetant, started 45 milligram per day. So in them, they can be potentially used in women with a past history of hormone receptor positive malignancy, where otherwise MHT is contraindicated. So neurokinin B receptor antagonist, a drug of the present and the future, we must become familiar with this. It is a very potent cure for, not cure, control for vasomotor symptoms. As very, very correctly Revati Madam said, that many times premature ovarian insufficiency, early menopause, and even menopausal symptoms at the menopausal age happens in cancer survivors which are having non-gynecological cancers. Like they are really potential candidates for estradiol therapy, and the decision to treat should be on the type of cancer, and as already told, it should be a shared decision. To give an example, systemic but not low dose vaginal estrogen is contraindicated in women with breast cancer, we already said. But in women, for example, with Hodgkin's lymphoma, who have undergone chemotherapy, which all can cause ovarian insufficiency, they survive the Hodgkin's, because Hodgkin's actually is a very, especially the non-Hodgkin's lymphoma is actually a curable cancer. And women do survive and live long, but in them, to preserve bone health and to prevent cardiovascular disease and to continue estradiol till age 50 years is actually having very good grounds. So therefore, please discuss and constant touch with your onco colleagues, because many oncologists may not be aware or may not alert the women for MHT, and it is our duty to see that women who have non-gynecological cancers, non-hormone dependent cancers like this, and thank you for bringing that out, Revati Madam, deserve MHT much more than other cancer survivors. So please look at it and please provide them. I think Beena was asking about endometrial cancer survivors, and do suffer a lot. And let me tell you that this is one area which is complex and multifactorial. Sexual dysfunction here will be related to the surgical procedure itself, because it is a radical surgery, or even the adjuvant radiotherapy and chemotherapy will lead to sexual dysfunction. And it is very important to address these symptoms. And treatments are available, and local estrogen can be used in these women if the endometrial cancer is low risk. The approach should be the risk status, mainly the risk status. So today, we are all very familiar that endometrial cancer can be low risk or high risk. Now, this forum, I may not be able to go into the details of low risk, but we know early stage and without LVSI invasion, and it is less than 50% of mymetrium, and it is a very low-grade adenocarcinoma. In such cases, estrogen replacement therapy actually is not contraindicated, and it should be provided earlier than non-hormonal treatment. So when I look up the evidence, I'm coming up with grade 2B evidence, which is a quite high level of recommendation, and there is no risk of recurrence in these women. Of course, we still have to be convinced, because endometrial cancer is also hormone dependent. But when it belongs strictly to the low risk category and the woman has completed treatment, remember, in these women, actually they do not have need for chemotherapy and radiotherapy also. In them, estrogen replacement therapy, estradiol alone, because no uterus would have been removed as part of surgery, is an excellent recommendation. And please read more about it and build up your capacity to prescribe estradiol for post-endometrial cancer, low risk. And as Seema said, we can respect the 2-year interval in them and then prescribe probably, but we have to deal with their symptoms in other ways still, and supportive treatment, and then still provide them with MHT.
What about
It is possible to give
ospemiphene,
very
Shobha?
guardedly.
What about
If it is
ospemiphene?
available,
You
yes,
mentioned.
ma'am. It can be
Yeah,
if it is
it should.
available. If
DHEA
it is
and
available,
ospemiphene,
yes.
these
It
two
can be,
things.
madam, if
Yeah,
DHEA
DHEA
locally,
is available.
yeah, yes, and estradiol
Ospemiphene,
cream also can be given in them. Estradiol
yes.
cream also can. Now,
And the-
in
No,
intermediate
instead
risk
of
and high
estradiol, you should go for the estriol cream. Estradiol is
estriol,
more powerful, so estriol is less powerful. That's why
yes,
you should
yeah.
ask them to take
Yeah, we can
estriol.
start with estriol cream,
Yeah.
and if that is giving relief, it is a good thing. Now, women with intermediate risk or high risk disease, that means all other endometrial cancer variations other than what I spoke about, especially the endometrioid, especially the serous, all of them are very high risk. And here we need to have a non-estrogenic treatment as discussed earlier. And estrogen may be indicated if the symptoms are not controlled, but then that has to be a shared decision and it has to be a very, very guarded decision. We come to the ovarian cancer. In menopausal symptoms in epithelial ovarian cancer, because I think I have deliberately kept out sex stromal cell cancer and germ cell tumors because there's huge paucity of data in those segments. So let us restrict ourselves to discussion on EOC only. And we do tend to offer non-hormonal as the first line measure if it is there. For those who have failed or declined non-hormonal treatments, we suggest hormone therapy rather than no treatment. So that is hormone therapy rather than no treatment if the non-hormonal has failed. That is grade 2C recommendation. Now, within 10 years of menopause or younger than 60 years, hormone therapy is fine. But please be sure, because we are talking about epithelial ovarian cancer, where there is a possibility of genetic mutations, there's a possibility of Lynch syndrome, etc. So please be sure that there is no history of breast cancer or any other event like coronary heart disease or previous VTE or stroke or active liver disease. Why this becomes very important is because epithelial ovarian cancers are typically seen in women of a little older age group, and these risk factors become important. This approach to patient over 60 years, right, can be actually there are some studies which say that some amount of hormone therapy can be prescribed even for women who are older, even though this has to be taken very guardedly. But the risk of breast cancer should be considered, and the genetic mutation should be preferably known, because we are talking about epithelial cancer. Now, most often they would have undergone hysterectomy, so we have to consider only estrogen. Sexual dysfunction is very, very common in them. They may be secondary to effects of the surgery, chemotherapy, or they may be due to the menopause which has been rendered, or maybe due to partner's sexual issues, etc. Because sometimes there is a lot of issue domestically also because of the diagnosis and the treatment of cancer. The woman may complain of dyspareunia, loss of desire, and that has to be actively addressed to improve the quality of life. Now, this is about the cervical cancer, and I think Seema very rightly brought out that whenever there is a cancer of the cervix, hormone replacement therapy rather than non-hormonal treatment should be offered for menopausal symptoms, for vaginal dryness, vasomotor symptoms, or dyspareunia. As a result of treatment, MHT will be required in them more vigorously. It should be more. We must prescribe MHT for cancer cervix survivors, because suppose if whatever treatment they have undergone, all of them have a huge impact on the vault and on the vaginal area, and therefore they will require help. Available data suggests that MHT does not increase the replication of human papilloma virus, whatever, because that stage would have been passed in them, but the risk of recurrence also is not there. And this is supported by several studies, and one which contained 120 patients with stage 1 or 2 cancers. There was no increase in 5-year survival amongst those who used or did not use, that is 80 versus 65, or in the incidence of recurrence, 20 versus 32. So that is quite reassuring, quite reassuring. Now, the concept of prescribing the hormone therapy in cancer survivors, every gynecologist should be very adept in prescribing low dose MHT. So the concept of low dose means that the lowest effective estrogen dose to relieve the menopausal symptom. So you want to not start the standard dose, but low dose, and then make do with it, because if that is giving relief, then so be it. Why to go for the standard dose? So this conforms to conjugated estrogen of 0.3 milligram, which is often not used. We are using estradiol 0.5 milligram orally, or a transdermal, a small patch, smaller dose patch of 14 to 25 microgram per day. And if we are using progestogen for a present uterus, then we must think of micronized progesterone of daily use of 100 milligrams, or a cyclic use of 200 milligrams, or dydrogesterone preferably 5 milligram, though it is written here 5 to 10, and an LNG IUS, which releases the least progesterone of all of this, right? Only few micrograms per day, 20 micrograms per day. Then what is the indication for low dose? Three have been mentioned. One is when the symptoms are very mild to moderate. One is the maintenance therapy after the first full dose has been done for a few days. And the third group is the group which we are talking about today, and that is the higher risk women as cancer survivors. What are the advantages? The advantages in cancer survivors, of course, that risk of recurrence, phobia, which people will have, will go away, and symptom relief with lower doses will ensure that there is a very low chance of venous thromboembolism. Please be mindful about venous thromboembolism risk. Constantly assess them for this risk, because cancer survivors may not be as active as their non-cancer survivor counterparts, menopausal women. Please see to it that they are on exercise schedule. If we start them on MHT, especially systemic MHT, we have to see that they have every prevention of venous thromboembolism. So the key point, of course, is to individualize and use the lowest effective dose, and use it for the shortest duration, and keep them under constant surveillance and with constant dialogue with our oncology colleagues in the survivor clinic. So today it seems like the train is well on the way, MHT train, and we would request as menopause practitioners, both the care providers and the patient population, not to miss the MHT express train. If you're not careful, you'll miss the train, and then the correct thing is not done for the woman at the correct time. So thank you for your patient audience. Thank you.
You brought all the details very beautifully in a very concise manner, Shobha. Excellent. So
Thank you, Jyotika.
we've had three lovely talks today, and I'm sure more people will prescribe MHT, especially the low dose one, since it looks more attractive than the regular dose.
Yeah.
I thank you, and of course, for asking me to be today. Thank you so much.
Thank you. Thank you, Jyotika, for being here. That is really good. Thank you.
Great, Sobha. It was really wonderful.
Thank you,
And
madam.
you
Thank you,
covered
Anita.
very nicely and precisely.
Excellent way of summarizing, Dr. Shobha.
Thank you, Revati, madam.
Another thing is that for GSM, for cancer survivors, again, first choice is non-hormonal. Then only if it is not relieved, or it is very severe, only you go for MHT. Just like any other patient.
This local image, local estrogen.
Local image.
Excellent talk, Dr. Shobha. You have taken all the minute details which we didn't even think of, besides explaining everything so beautifully. Thank you, Shobha.
Thank you, Bina. Thank you so much. Thank you.
Thank you, Shobha.
Thank you for joining.
Summarization.
Thank you.
Bolo.
Thank you so much. Thank you for joining.
No, actually, my internet connection was a bit interrupted. I was there out, but since I was...
Ambuja ma'am and Anita and Ragini, all of you, Vipasha and me have an equation. We will meet in every conference and we will take a picture. Somehow, I don't know, in that crowd of AICOG also, I met her, and it was so nice to meet her. Yeah. So now I think Anita ji, vote of thanks में हम किसको बोले? रीना जी को बोले, पद्मजा को बोले. Who will give the vote of Padmaja? Can you do the honors of vote of thanks? You will do very well, I think. Hi, Padmaja.
Thank you, Dr. Anita, for letting us do something a little different rather than just talk about the theoretical things that are available, how to put that into practical use. Thank you,
Yes.
Dr. Ragni, for always being there, and the entire team who have been there, supported us, and Dr. Shobha for making it a very doable thing. You've given us, given a lot of people the courage, like, okay, fine. It's not as bad as we think. It's not as bad as it is publicized in papers that hormones cause cancer. And in fact, quite a large number of even the physicians refuse to let women use hormones, not
Yes.
just for MHT, even for pills, even for contraception. When we think that it's
Yes.
one of the biggest liberating things that women can have, everyone
I think
pulls
it's a constant, you have to fight against people to
yes,
prescribe
yes,
hormones.
yes. I think our women are informed enough, and they're moving forward in life. And I think if we tell them the risk benefit analysis, I'm sure more number of women will be willing to have a very active life, taking into consideration the small risks that are there. Because you have, as always said, it is not how many years we live, it is how well we live those years that matters a lot. And that's what we are all striving for. Thank you very much.
So
And
well said, Padmaja. So
yeah.
well said. Yeah.
And we thank the IMS for giving us this platform to share all these ideas. And thank you, Paresh, for being there and putting up the flyer.
Yeah.
Thank you very much.
मुझे रीना से
I'm-
पूछना था, कुछ बोलेंगे क्या?
Yes. I would like to say
रीना जी से
that
पूछना था,
these
कुछ बोलेंगे क्या?
seminars on e-prescription throughout the year have been so very well designed and so very well executed. And I think a lot of beautiful messages have been taken by the general practitioners even. We too are so much, I think, more intelligent in prescribing these medicines. And today's seminar was, I think, the best graded one, because a lot of confusions were there regarding MHT in cancer survivors, and they have been put so nicely with all by all of the three speakers. Very brilliant, very nice. And throughout the year, the e-prescription workshops have been validated at a high grade by all the listeners to whomsoever I talked to. And it was a real, we can say, pleasure, entertained with all these seminars. Thank you to all the organizers, especially
Thank you so
Shobha,
much.
you
It
have
was
done
nice.
a great,
It was a very
great job.
beautiful experience.
And my thanks to
अरे
the
अरे, ऐसा
president, the
नहीं,
secretary,
सबका साथ है.
all the coordinators.
Yeah.
It was really wonderful enjoying these seminars.
I think we need to kind of really acknowledge that this year our president has been so giving, so magnanimous, so generous.
Sweet.
And
Yes.
absolutely, because it's
Sweet of
very,
her.
leadership with so much of generosity,
Yeah.
we must welcome and we must embrace it whenever
Yes.
we see. It is really great. It is really great. And so humble.
Thank you to
And yeah, very
that's
nice.
why
I'm
a
so lucky
big
that
thanks to
all
them.
of you have cooperated in such a way that we can execute all these things. Otherwise, we know everything, we want to plan also, but if there is no proper cooperation, coordination, then we can't do it. But I'm so lucky that all seniors have guided me in such a nice
Yes.
way,
Mhm.
and all my colleagues and juniors have also helped me in such a way that I could do my best, whatever I can do. And
It
thank
was
you very
great.
much for this prescription writing webinars.
Thank
Were
you.
really wonderful, and really I can say need of an hour, because we know everything, but to put in the practice is sometimes very difficult. We are
Very
also
difficult.
hesitant. And so I think by all these prescription writing webinars, many of us would have taken a lot of good messages, and they will definitely put it in practice. And only then we can fulfill the slogan of our Indian Menopause Society, which elaborated by me as fit at 40, fancy at 50, strong at 60, sexy at 70, independent at 80, naughty at 90, and healthy at 100. So we want that each and every midlife woman should
So we
be
are
like.
not yet sexy if we are not 70.
No, you have to become.
I'm just wondering how a 90
Dr. Anita,
It can be naughty.
I hope
Yeah.
this is not getting recorded.
I'm going to give oration also on that topic only. So I'll be
Wow.
getting
Full-fledged. बहुत अच्छा.
डॉक्टर अनीता डॉक्टर
Yes,
अनीता
yes.
एक सजेशन है फ्रॉम हैदराबाद से.
हाँ
हेलो.
बोलो ना.
बोलिए
हाँ,
बोलिए संध्या
एक
मैम.
चीज है, ऑल दीज प्रिस्क्रिप्शन राइटिंग वेबिनार्स, कैन यू गेट वन बुक फॉर्म कंपाइलिंग
Yes,
ऑल ऑफ
yes.
देम सो
Sandhya ji, we are planning that. And हम आपके beloved मैडम ही हमको गाइड कर रहे हैं. मैडम is doing peer review for that, and we are just planning, and we will just release at the time of inauguration.
very good, very
Will
good.
be ready.
Because we have missed some and it is our last, so we want to have one book form we can now and then go through and
We are planning.
Yes, yes. We are.
reference.
It is all done. It is all done. Actually,
Oh.
मैं 6 modules हो गए ना Anita ji. I sent you the 6th one also. 7th
Yeah.
and 8th only are remaining. Yeah.
Oh, very good, very good, Shobha, very nice.
Yeah. Thank you, Sandhya ma'am. And please
Yeah.
read and please
Yeah.
give to everyone. Please
Yeah.
keep it on your desk.
Yes,
And
it should be a coffee table book. Yes.
Yes, yes.
Correct.
It is something like that only.
Yeah, yeah,
No great editorial work.
No,
Nothing
it
much.
will
It
be
is
just like ready record.
simple.
It will be just
Ready,
like
ready
ready
reckoner.
record book.
It should be a ready reckoner for prescription.
बिल्कुल बिल्कुल.
Yeah,
But
yeah.
all
It is like that.
valid data, all authentic. मतलब कुछ भी
Yes.
हमारा नहीं है. जो
Yeah.
भी evidence है उसी को crystallize कर
Yeah,
करके.
yeah. Yes,
Is good.
yes.
Very. So we are.
Actually, many more could have attended
help.
because more than a book, attending this webinar is very, very
Yeah.
interesting and useful.
Yes. Mhm.
More than a book.
Yeah, yeah.
Hello.
Yeah, but sometimes we miss attending or we join late, so we'll miss some.
Today also only third, fourth
points.
year. Many of our members should utilize the opportunity, this opportunity.
Yes, that is why. That is
But
why we
nothing can be done.
Thank
My
you very
God.
much, Ambuja madam, for being kind, for doing peer review of our this prescription writing book.
Handbook.
handbook.
Thank you,
Always
Anita, for giving
remaining
the
with us.
opportunity. Anybody will do it. You gave me the
No,
opportunity.
madam, not like that.
And I had the privilege
No,
of
madam.
looking at all these things. Until now, I did 5 modules. I think 6th one is waiting there. I
Yes,
thought
madam.
after finishing this, I will do it.
Yes,
All the
madam.
5
Thank you.
wonderfully. And this is Dr. Shobha who managed it so well.
1 year. So done a good job.
Yeah. You have the passion to do it also, Ambuja.
Big
Yeah.
round of applause for everyone who supported for all this.
Thank you, madam.
Thank you. Thank you. I think
Thank
we will wind up.
Okay.
Thanks a lot.
Thank
you.
Meet you all at Bhopal.
Tomorrow we will
Yes,
meet
yeah.
for Menopause
Yes.
Cafe. Tomorrow we will meet for Menopause Cafe.
Cafe. Yes.
Okay.
Yeah. Okay.
Bye.
Bye,
Bye.
everyone.
Bye.
Bye,
Good night.
everybody.
Bye.
Bye, Deepa. Yeah.
Bye, bye,
Bye.
bye.
Bye. Bye.
Bye. Yes, madam. Good evening. Thank you.